introduce you.
Sure, thank you.
Dr. Prakash Muthusami is Assistant Professor, Pediatric Interventional in Department of Diagnostic Imaging in Hospital for Sick Children, University of Toronto. This lecture is about pediatric neurovascular disease. Dr. Prakash, thank you so much for accepting our invitation. It's a pleasure for us.
Thank you. It's a pleasure for me to give this talk to you guys, and I wish we didn't have to do it virtually, but you know how they say, if life throws lemons at you, you have to make lemonade. So, this is our lemonade. So, I'm a neurointerventional radiologist at Sick Kids. So I work with children in both diagnostic and interventional therapies. And I'm going to talk a little bit about these things over the next 40 or 45 minutes. And hopefully I'll leave some time at the end for questions. So this is an overall look. If you look at all pediatric neurovascular diseases, you can generally divide them into these big categories. So the high flow malformations, which is essentially an artery connecting to a vein, and you have no intervening parenchyma or bed in between. And then you have the low flow malformations, which are basically errors in the development of capillaries, arteries, or veins. So you have the venous and lymphatic malformations, or you can have the tumors. And then you have the miscellaneous other non-shunting lesions. So for today's talk, I'll concentrate more on these high flow malformations, the complex lesions like AVMs, PL, AV fistula, vein of Galen malformations, and a little bit I will touch also on some of these low flow malformations. And hopefully, if you have another session or time, I can talk more about things like aneurysms and stroke and tumors and things like that. But for today, I'll concentrate a little bit on these high flow malformations. So this is very important for all of us to know whether we are in the diagnostic side or whether we are treating. And I often get these referrals of fetal MRIs or neonates with the diagnosis of AVM. And remember, the AVMs almost never occur before infancy. I have never seen one. I have never seen anyone who has reported one to me. And that's because of the genetic development of an AVM. So in the fetus, newborn, and infant, what we see more commonly is PL AV fistula, dural AV fistula, and vein of Galen malformations. More commonly, the AVMs we start seeing after toddlers or preschool. In fact, the peak, as you can see here, is in the teenage. Of course, the largest peak for AVMs, as you know, is in sort of middle adulthood, 40s or 50s years of life. But in childhood, the peak is somewhat at teenage, and it is extremely, extremely unusual to see anything before this age of 1 or 2 in terms of an intracranial AVM. So let me start with the story. So this was about 2 years back, and we had 2 babies who were diagnosed with fetal MRI with PL AV fistula, and they were delivered and came to the NICU, and the neonatologist called me to examine the child and look at them. So there were 2 children. They were both in the same unit. They were in opposite beds. So one in the bed and the other one in front of him. And both of them were around 2 kilograms. The first baby was doing extremely well, was breathing in room air, feeding well, and interacting with his parents. And the second baby also around 1.8 kilograms, having the same diagnosis of a PL AV fistula, but was in severe cardiac failure. We could actually hear a cranial bruit on the skull. And the family was obviously very distressed because they don't understand why this child having the same diagnosis as the other child, but is doing so badly. Is there some management failure? But it is important to understand the pathophysiology of these conditions. So let's look at baby A. This is what we call a single hole fistula. So you can see on the image of the time of flight MRA, you have the artery that is directly communicating with the vein. And this is a PL AV fistula in the form of a tube to tube. So one tube connecting to another tube, and that is a single hole fistula. And you can see there's a little bit of mass effect, but the brain is well preserved. There is no damage. On the other hand, if you look at the second baby, there are multiple fistulae connecting into the vein. So this is a classical multi-hole fistula. So you have multiple tube to tube connections, and this causes a very high flow situation. It causes edema. It causes venous congestion. You can see the varicose veins in the brain the mass effect, the hemorrhage has already occurred. There is a lot of white matter edema and mass effect as well. So the first baby we were able to wait, and we saw at about 3 months that this pouch is starting to grow in size. So we did an elective embolization, went very well. You can see this is after injection of 100% glue, completely cured that AV shunting. In fact, you can also see before how the steel was happening inside the brain, and after we cure it, how the brain is now supplied nicely with blood because of closing that shunt. And this is the MRA after 1 year showing an exclusion of that lesion. And the MRI showing the brain has healed well. And this child is going to have a normal development like any other child of this age. In baby B, because of this situation of multi-hole fistula with edema and hemorrhage, we took him for an emergent embolization. And you can see here the multi-hole, multiple arteries going into veins, multiple embolization, glue injections later. Unfortunately, this child had massive hemorrhage. You can see an increase in the edema. There's clotting, more venous congestion, and this child we had to pull the life support, and this child did not survive. So we have here the same disease, but because of a completely different pathophysiology of the same diagnosis, we have completely different outcomes. So it's important to understand not just from the anatomical point of view, but also from a pathological point of view and hemodynamical point of view, what happens in these conditions. So the natural history of these PL AV fistulae is poor, even if there is no hemorrhage. So as you can see, this is the same child I showed you before, and you can see here the steel before and after we treat, how nicely the brain is perfused. So this is a color-coded DSA map showing before and after the embolization, and you can see how much steel is happening in the brain. And because of this chronic ischemia, you can have a number of things. If this is not treated over the years, these children have cognitive decline because of this cortical atrophy, chronic ischemia, and they can develop calcification of the white matter, delayed myelination. And if this disease is left alone, in older age groups, they typically present with ventriculomegaly, macrocrania, seizures, and recurrent strokes. Now, the genetic signaling behind this disease is not clearly understood, but we understand that there is some persistence of a primitive arteriovenous connection, which does not go away. So before the age of 8 weeks, there are some arteriovenous connections which are there in the normal state. And in these PLAV fistula, maybe they don't go away. Another hypothesis is that the closure happens, so the division of the artery and vein happens, but then during embryogenesis, a new connection forms, causing these AV shunts to happen. The Notch pathway is being given a lot of importance in this. So depending on the signaling of the Notch pathway, if you have an uptake of ephrin B2, the cells differentiate, the endothelial cells differentiate along the arterial side. And if ephrin B2 is suppressed and ephrin B4 is upregulated, then you have the endothelial cells differentiating as venous cells. So if there is an imbalance in this ephrin B2 and B4 pathway based on the Notch expression, you can have these capillary level malformation, which does not differentiate into an artery or a vein and instead hooks up to form what we call AV fistulae. So these can be associated with these syndromic conditions like HHT, hereditary hemorrhagic telangiectasia, or RASA1 mutations. And it's very common to see these kind of venous ectasias in these conditions with PLAV fistulae. So here's a 3-year-old who has HHT. And when you see this picture with these venous varicose veins and enlarged arteries feeding into them, you should start thinking about these conditions like HHT and RASA1 mutations. And as I said, these need to be treated early, not just for hemorrhage, but also because they tend to do poorly in the short term as well as in the long term. Now, they can also present acutely with rupture. So it's not always for a delayed cognitive improvement that we treat them. They can also present very acutely. For example, here's a 2.5-year-old girl who presented with sudden neck stiffness and loss of consciousness. And she has this AV fistula from one of the basilar perforators going into this enlarged vein. You can see the edema and mass effect in the brainstem over there. So there's the DSA. You can see the AV fistula, which I have shown on a still image on this side. But also what you can see is the venous reflux and engorgement inside the intracranial circulation and the complete steel from the vertebrobasilar circulation. Nothing goes inside the brain. And you can also see the spinal congestion, spinal venous congestion. So this child will not do well unless treated. So we started treating by coiling this fistula. You can see we have two microcatheters. The tip of one is here. Here's a second microcatheter. We coiled this fistula, and then when I did the test injection, I then saw there's a second fistula over here. So sometimes you can miss these fistula because there's so much happening. There are so many engorged veins. And it's very important to appreciate that there is a second fistula, because at this moment, if I inject glue here, what will happen is the glue is going to get sucked towards the other fistula. And this will go all the way backwards into the vertebral and basilar artery, and I will end up with a massive stroke. So it's very important to do these check injections and recognize these things as you do the procedure. So then I switched, started coiling the second fistula, completely closed the fistula, and then came back. So now you can see this fistula is completely closed. Small amount of trickle shunt is left behind in the first fistula, and now it is safe to go back and glue the first fistula without having fear of the glue being sucked into the second fistula. And by this, we can achieve a complete control. So there's a complete exclusion. This is at 3 months, and this is at 1 year. So no recurrent shunt, and these children will do very well. It's very, very unusual for these kind of fistulae to recur in later ages. Now, even though I said a single hole fistula, remember it doesn't always have to have one feeder. The shunting zone of an AV fistula can recruit many arteries to the same spot. So look here in this, you have this large superior cerebellar artery, but you also have a pica branch which goes to the same spot of this AV fistula. And you have some smaller arteries coming, which are cerebellar arteries, all go to the same spot over here. And then it is easy to cure this because you basically have this particular zone. This is a shunting zone. So we eliminate the feeders as well as the vein and the neck of that fistula where they communicate. So this zone is the zone that we have to take down. So in this case, I slow the flow down with coils and then inject glue so that I take this entire zone. Basically, this would be the zone that would be resected if it was a surgery. So we replicate the same thing in an endovascular fashion. Now this child also has HHT, and if you look here, you can see there's another shunt happening over here. And this actually was an AVM on the surface of the brainstem, and it was treated surgically because of the direct supply from the anterior medullary pica. So whenever you look at HHT, they have to be always followed up for developing further AVMs and for recurrence as well. So let us switch a bit to vein of Galen malformations, which is essentially the persistent arterial anastomosis to this median prosencephalic vein. So what does that mean? Let me explain it. Okay, so this is the embryological brainstem. We are looking at it from the undersurface. So this is the undersurface of the brainstem. Here is anterior and here is posterior. Okay, so between the weeks of 6 and 10 or 6 and 11, the choroid plexus, so these two are the choroid plexus, are fed from the choroidal arteries and the anterior communicate and the anterior cerebral artery. So this is the limbic arch, which feeds the choroid plexus, and this choroid plexus drains backward into this median prosencephalic vein. So this is the normal drainage pathway for this system. Now, over time, what happens as we normally mature, these two veins come and develop. So these are the internal cerebral veins, and these veins hypertrophy and they start draining the brainstem, and they hook up into this median prosencephalic vein. When this process starts, this part, the anterior part or the ventral part of the median prosencephalic vein regresses. And then we get a normal anatomy where we have the internal cerebral veins joining into the vein of Galen, as it is called later, and then the straight sinus. But what will happen if this is not allowed to close? Suppose we don't allow this to close because there are AV shunts that are communicating directly into this. Then instead of regressing, it actually hypertrophies, it balloons, it becomes big, and then we end up with this situation. So this part of this median prosencephalic vein, which normally should have regressed, has now become a balloon, and that we call the vein of Galen aneurysmal malformation. So obviously in this, we also see many other abnormal structures which are embryonic. For example, you see this Falcine sinus, which is an embryonic sinus. You see this limbic system, the limbic arch, the ACA, as well as the posterior choroidal arteries, which hook up into that vein of Galen. And most commonly, you do not see the straight sinus. The straight sinus will be atretic, or it will be very, very small. So this is a classical imaging findings of a vein of Galen malformation. And more we recognize them by fetal ultrasound and fetal MRI. where it has this classical picture of a supratentorial midline cystic lesion with very high flow with shunting, as you can see here on the Doppler. So we usually tend to, as far as possible, unless there are these poor prognosticators like hydrops or tricuspid insufficiency, we try to delay the delivery until term. And it is a very combined effort, obviously, with fetal medicine, with neonatology, with ourselves, with the ICU, cardiology, and so many teams that are involved in this initial phase of the child's birth and postnatal period. So this is the physiology and hemodynamics of the vein of Galen malformation. And most of the time, we have to understand that these do not show their full representation as a fetus because you have the placenta. As a fetus, the placenta takes the role of the lowest resistance. So most of the blood is going through the placenta, and it does not allow shunting through the vein of Galen. As soon as a child is born, the placenta is removed, and now the lowest resistance is now your vein of Galen. So that suddenly becomes this huge shunt, which is shifted from the placenta into the vein of Galen. And then you set up this loop where all the blood goes out into the shunt and then back into the right heart. And then you get this increased preload to the right heart, you get pulmonary hypertension, edema to the lungs. And if there is a PFO and PDA, that allows the pulmonary artery to shunt out into from a right to left fashion. And then over time, these children can also develop cyanosis. Now, what happens when the shunt is so high that it does not allow the blood to go down the aorta? Everything is being sucked up into the head. Even everything that is coming through the PDA is sucked up into the head and nothing is able to go down. On the Doppler, you see this characteristic reversal, the holodiastolic reversal of descending thoracic aortic flow. So everything that should go down is now going up through the shunt because the shunt is so voluminous. And this can cause a lot of secondary features like renal failure, liver failure, gut ischemia. And these children tend to do very poorly. So if you see reversal of aortic flow on your Doppler, that is an indication for emergent treatment right there. The other thing which happens with that reversal is the duration of your diastolic period becomes so small that, as you know, in diastole is when the cardiac tissue obtains its oxygen. So the diastolic period becomes so short that these children go into myocardial ischemia and can have massive MIs. And we actually had one child who had a massive MI and passed away from this exact phenomenon. So even if these children are well when they are born, they can acutely decompensate because of this pathophysiology, which I just described. And the first steps are obviously medical management of the cardiac failure, multi-organ failure with respiratory support. We keep all these babies on continuous EEG. On day one of their birth, they receive an MRI of the brain to see the prognosis, and they receive daily transcranial Dopplers as well. As far as possible, we try to delay embolization for about 3 to 6 months. And the reason for that is because early embolization has been shown to have high complication rates because the brain is immature up to the age of about 3 to 6 months. And of course, even after that, but the complication rate at that period is extremely, extremely high. As you can see here, there are brain complications in about 30%, mortality of 30%. And even when they do well with embolization, the outcomes are poor in about 30%. You can have access site complications. So one of the things that we tend to do is we ask the neonatologist to leave an umbilical arterial access, and if the embolization is needed in the first week of life, we go through the umbilical access. As you can see here, I put a 4 French sheath with a double wire technique, and through this we can proceed with embolization sparing the femoral. So these children with time also develop what is known as hydrovenous disorder, because in the infants, the CSF absorption is dependent on the medullary veins, and all these veins are congested. They are not able to flow out because they are arterialized by the vein of Galen malformation. The cavernous sinus is unable to do its job until about 6 months. So the whole brain is dependent on the posterior sinuses, but the posterior sinuses are arterialized. So how does the brain flow? So there is this hydrovenous disorder which is set up. The CSF absorption fails, and then the child starts developing two things. One is ventriculomegaly or hydrocephalus, and then macrocrania. But also what happens with arterialization of these venous sinuses is that they start developing poorly. There is a maldevelopment and stenosis. So at the outflow of the IJVs, they start getting narrowed and stenosed. And then that increases the back pressure and it sets up this cycle of a hydrovenous disorder. So this over time leads to what is called the melting brain syndrome. And if you see this picture in a neonate with vein of Galen malformation, it is a very poor prognostic indicator. So the brain, as you can see here, has become small in size, the ventricles have increased, there's calcification of the white matter. And basically what that means is that there is a lot of hypoxic ischemic injury secondary to this venous congestion and back pressure changes. So the typical progression of this is to continue with calcification and cavitation, and at this point we would discuss care withdrawal. So we tend to treat these transarterially and not in a transvenous fashion anymore, but the goal of these treatments is to restore the normal development of the brain and the normal cognitive development rather than a normal angiographic appearance. So here you can see AP and lateral pre and then post glue injections, how we are in each session reducing the shunting to some extent, but not all of them require complete exclusion of a shunt, because with each procedure we also have an element of risk. So the mural types of this, what I showed you here is called a choroidal type of AVM, and you can see, sorry, a choroidal type of vein of Galen malformation. And you can see these multitudinous vessels, many small arteries. Almost it looks like there's an AVM and then it goes into the vein of Galen malformation. But these are all arterial feeders and they hook into the vein of Galen malformation. And this is called the choroidal type. The mural type is where you have one. So here you can see there's one large feeder that goes straight into this vein, and that's called the mural type. These are typically better tolerated. They don't have heart failure. They can be watched with medical treatment. And this is actually a child that we had earlier this year. And there you can see the shunt actually has a normally developing straight sinus. So all these are better indicators of prognosis. So this means that the shunt was not such a high volume. It developed later in fetal age. And the child was able to develop even normal internal cerebral veins, as you can see here, hooking up to the vein of Galen malformation. So these are signs that this child will probably do well. And indeed, when this child was born, we were able to watch him with multiple MRIs. And in fact, last week I saw this child. He's at about 6 or 7 months after birth, and we are now planning to treat. You can see now we can define very clearly where the shunt is. You have this large feeder, you have a shunt in the vein. And of course, we don't want to keep this going for a very long time because they will start developing cognitive delays, venous hypertension. They can have cerebellar edema with Chiari malformation, ischemia, and so on. So at this time, the child is developing well, the brain has developed well, and it is a good time to treat this definitively. So the dural AV fistulae in children are very different from the adult type of dural AV fistulae. And the common ones we see are basically these two types, the dural sinus malformations and the infantile type of dural AV fistula. So these are basically because there is a weakness in the wall and some sort of a secondary insult, which may be a thrombosis. And these typically happen around the 3rd intrauterine month. The pathophysiology is very similar, with neonates presenting with heart failure, hydrocephalus, failure to thrive. And then that sets up the similar pathophysiology of chronic venous hypertension. So this was a baby you can see with this enlarged dural sinus. And this is called a dural sinus malformation, or a DSM. And what is happening here is there are multiple dural feeders which hook up directly into this venous lake. So this is a torcula which has now been replaced by this venous lake. So unlike the dural AVF in an adult, where you have the fistula in the wall of a previously thrombosed dural sinus, these are actually direct shunts which come and open into this dural sinus. So what happens is the sinus over time gets arterialized and enlarges and enlarges. And then what happens is the brain is not able to flow out because the brain also requires the same torcula to drain. So this actually has a very poor prognosis. You can see here, this is again, I did this through the umbilical access, and you can see all these dural shunts. So you can see the difference here between the adult type. These are direct shunts which open into this venous lake. And you can see the swirling of flow. There are multiple shunts. This is the posterior meningeal system. And what happens is now the brain is unable to drain because the brain needs this torcula, but the torcula is arterialized. So what happens, it sets up again venous hypertension, venous congestion, and you can see this baby already developed a venous infarct over here. And this is the natural history with venous hemorrhagic infarcts. So this is an angiogram before the embolization. You can see here the glue injection through the middle meningeal feeder, and then the onyx cast through some of these other networks. And then we are able to completely close this dural sinus malformation. Remember here, we always have to balance, because you are injecting into the dural sinus directly. We don't want thrombosis, so we do an aggressive heparinization after these procedures, because we don't want that obviously to clot and then the brain cannot drain. So this is the MRI after 2 years, and we can essentially achieve normal development, and this basically looks like a normal brain development. Now, I showed you that the torcular or midline DSM, or dural sinus malformation. Here is a lateral or transverse dural sinus malformation. And these are typically better tolerated because obviously you are not involving the midline, and the brain can drain out from the other side. But here's a 4-year-old girl who presented with seizures, and you can see she also developed a venous infarct in exactly the same location. And what is the reason of this? Now, the first baby I showed you developed the same thing as a fetus, but this child has had this disease and then presents to us after 4 years. And the reason for that is because this dural sinus malformation, which is arterialized, now starts stenosing. So there is no outflow because of the maldevelopment of the IJV. The outflow gets completely stenosed, and now it starts refluxing into the brain. And then you have an arterialization of the brain dural sinuses, reflux into the brain, venous hemorrhages, and then they present at a more delayed fashion. And here you can see some of these shunts going inside the dural venous lake. So again, here is the external injection and the internal injection. You can see there are not only dural fistula, but also here's a PL fistula, which has again opening in a single hole fashion. So if you study this carefully, you can see there is one location where all the arteries come and unite and open into this venous lake. And then you can see there is no outflow. The outflow is completely I should not say thrombosed, it is completely stenosed. So everything goes backwards. So the flow is retrograde. Now the torcula is arterialized, and the brain is again suffering because it cannot drain. And then there is reflux into labae, which caused this kind of venous infarct. So this is relatively simpler to cure because we have a non-functional venous sac. So there it is. So you see the anatomy. There is no outflow. There's a reflux going all the way across and even up into the superior sagittal sinus. So here, basically, what we do is we get into that venous sac, coil it, and then we start taking down that site where the artery meets the vein. So now we completely close that with coils as well as onyx. There's onyx cast going into all those dural feeders, and we're able to achieve complete cure. And this is her MRB after 1 year. You can see the brain has developed a normal drainage pathway. It is not dependent on this anymore. There is no reflux now. And in fact, there's a occipito-marginal sinus, and the IJV is now open again. Lastly, the extracranial lesions sometimes can behave in the same way. So here's a baby with a very large congenital hemangioma, and most often these are involuting spontaneously. So if you leave these for 6, 8, 9, 10 months, they go away. But sometimes they present with, so we had one which was over the eye, and then that has to be treated. In this baby had cardiac overload and could not be medically managed, as well as presented with seizures. So we decided to treat, and you can see here these occipital emissary veins, because of which all the blood is going intracranially. And on the time of flight MRI, you can see these arterialized dural sinus as well as steel from the vertebral artery. So all the blood from the vertebral artery is going into the occipital artery and feeding this hemangioma. And there you can see on the venographic phase how the blood is taking over the intracranial system. So basically, this was treated by gluing each of these branches. So there's a glue cast, you can see multiple branches, and then coiling across this communication. So you know the vertebral artery and the occipital artery have a communication, and to prevent that vertebral arterial steel, we coil across its communication, and then you can see post-operatively there is no further steel. So now you have a normal appearance of both the vertebral arteries. And here's the dural sinus before the treatment with the arterial pattern, and after the treatment with a venous flow. So we are able to completely take down that arterialization of the brain sinuses. So to summarize this whole early sort of infancy and toddler till that point of time, these high flow shunts, mostly the PL fistula, dural AV fistula, and Galen malformations, they generally have this picture of a very early presentation of congestive cardiac failure, and they need aggressive medical treatment. They can have organ failure because of hypoperfusion, and as I said, they can also have coronary ischemia and pulmonary hypertension with this right to left shunting. Intracranially, as we saw, they can have both on the venous side, venous congestion and hemorrhagic infarcts, but also arterial steel and ischemia. And then over time, they develop this hydrodynamic disorder with progressive hydrocephalus and white matter dysmaturation. Now, coming to the hemorrhage part of it, we saw the PL-AV fistula and the dural AV fistula with hemorrhage, but it is very, very unusual for a vein of Galen malformation to present with hemorrhage. And if you do see a vein of Galen malformation with hemorrhage, you should think of whether it's actually a nidal AVM, and look very closely for a vein draining into the vein of Galen, rather than a true vein of Galen malformation. So we switch to a little older age group, so the AVMs in the children who are a little older. And as I told you, the peak happens in teenage. Most commonly, they present with hemorrhage, and in the literature, it says about 20 to 30% have associated pseudoaneurysms, but we have found we do a before 24-hour catheter angiogram for all ruptured AVMs, and we have found a 50 to 66% association of pseudoaneurysms. And most commonly, these are from perforating feeding arteries, but they can also be intranidal. So the intranidal pseudoaneurysms are venous aneurysms. The perforating arterial pseudoaneurysms are typically from the feeding artery, so they are arterial pseudoaneurysms. Here's one in the frontal lobe. You can see the rupture point in the form of a pseudoaneurysm, which I was able to get in with a microcatheter and selectively glue. So when you're doing the imaging of these, I find it very useful to look at MIP images, to look at these pseudoaneurysms. Often they can be hidden inside, and if you look at an image like this, it's very hard for you to see where a pseudoaneurysm is, or is it a venous pouch, or is it actually just a twist in the vessel. And that is another reason why the catheter angiogram almost always is essential. So here you can see the pseudoaneurysm with a feeding artery, perforating artery coming from the choroidal circulation, and then you can see it also on each of these images. And there's a microcatheter injection on the lateral, and we're able to define the pseudoaneurysm before a glue injection. So this targeted embolization is something that we do and we have been doing for a long time for rupture points. The pseudoaneurysms basically represent the rupture point, and they have a very high re-rupture risk, and second ruptures are often poorly tolerated. And the embolization of these rupture point is done not for a curative purpose, but of the AVM, but it's only to close the pseudoaneurysm. It allows us to control much better the medical treatment for these patients. And as I said, it also reduces a re-rupture risk for these patients. So we are quite aggressive in trying to get into the nidus and trying to, so here you can see this is just a very focal closure of this nidus with glue, although we leave the rest of it and come back at a later time for a curative treatment. Now, when you do the angiogram, you'll often see that these are sometimes small AVMs and you don't know why it ruptured. But if you look closely, you will see that there are often areas of venous stenosis, and often it is where the draining vein joins with the dural sinus. And these stenosis can often be far away. So here you have an occipital AVM draining, and then there's a stenosis. But here's a frontal AVM draining through labae, and all the way at the same location as there, you have a stenosis. So this stenosis can be quite remote to the actual site of bleed. And this stenosis causes the back pressure to build up, and then you have these venous pseudoaneurysms which rupture. Another important thing is when treating these AVMs is to recognize perinidal angiogenesis as not part of the AVM. So for example, here we have a diffuse AVM, which is fed by the MCA. Now, if you look at these PCA and ACA runs, you can see that there are these very small arteries that hook up to the corner or to the edges of the AVM, and these are collaterals. They are not true feeders of the AVM. And how you recognize them is by this appearance of these arteries, which become smaller and then bigger and bigger and bigger, and then hook up into the AVM. And again, here you see these arteries, they become smaller and smaller, and then they become bigger and bigger, and then hook up into the AVM. So in this case, these are the collaterals. They are not true nidus. So again, PCA collaterals, ACA collaterals, and there is a true nidus. Only this part needs to be treated either with embolization or with gamma knife. You would define only this part and leave. So these will regress after you treat the nidus. And you can see these classically on a T2 weighted image. You can see all these little branches which are inside the gyri, but they are not inside the true nidus. So the nidus is over there, but all these branches come and hook up to the corner of that. So whenever you see multiple lesions, think of those conditions I told you, especially HHT and RASA1 mutation. So here's an 8-year-old girl with HHT, and she presented with incidental non-rupture AVMs, and there's one in the frontal lobe. And then she also had this non-shunting lesion, which is a capillary malformation. The most common lesion in HHT is a capillary malformation. But you have to follow these capillary malformations over many years. We have seen some of these lesions. They are actually micro AVMs, and over the years, they start becoming shunting lesions and AVMs, and then eventually they need to be treated. So in this particular condition, HHT, you have to follow these patients. Now, for the other patients who we treat, even whether it is surgically or endovascularly or with gamma knife, we have seen, and across the literature in children, there is a 10 to 15% recurrence rate, which is not recognized in adults. And the reason for that is probably VEGF-mediated angiodysgenesis, because the endothelial cells are able to be activated and create immature vessels in children, which does not happen in adults. So we follow all these children with catheter angiography, which we do at 1 year as well as 5 years. And in the interim, they continue to receive MRIs, and we follow them well into adulthood for seeing if there are any recurrences. So last time we looked at our MRI to look at the sensitivity and specificity of these contrast-enhanced MRI and time-of-flight techniques. And you can see that when we combine these two techniques, we get a very high positive and negative predictive value to diagnose recurrent AVM, but it's still under the 90% mark. So what we found actually was that the best way of actually predicting, increasing this predictive value to more than 95%, almost 99% actually, is to do this MRI DSA fusion. So what we do is we use the 3D catheter angiography and fuse it to a non-gadolinium MRI, and then you can see that. So this is an actual gadolinium MRI, and this is a fused image. So you can see that the gadolinium enhancement in this case is not true nidus. It was actually just scar enhancement. So these kind of cases you can eliminate very confidently, because you can see very clearly that this is not an AVM, this is nidus, and these children do not get these false positives. And similarly, you can reduce also the false negatives. And these kind of fused images are also very useful for intraoperative neuronavigation. So here is a MRI DSA fusion image, axial and coronal, and a very small recurrent nidus. So this child had a bleed, was treated, almost 8 years later came back with a recurrence. And this is very difficult to see on a regular GAD MRI or a time-of-flight MRI, especially in these small children with poor spatial resolution. Very small nidus, but you can see how clearly you can see it here on this fused image. And then this image becomes crucial to use in the intraoperative neuronavigation for the resection of these AVMs. So I'll touch a little bit on aneurysms, but I'll go into some of the more common aneurysms in children. So here's a 5-year-old boy who came with headache and vomiting, and you can see this this balloon-like lesion on the CT, as well as a flow void on the T2 MRI, a little bit of susceptibility, but it fills entirely with contrast. There's the catheter angiogram, which shows the PCA is ending inside this dilated sac, and then there is no outflow from it. So this is not AV shunt. So even though it looks like that, the AV fistula with a dilated vein, note that in this case there is no shunting happening. So the artery is coming and terminating inside this lesion, and what this is actually a dissection of the PCA. And you can see when the P1, P2 crosses the tentorium at this site, it is relatively fixed against the edge of the tentorium, and this is a common site for the PCA to get dissected. And it is more common in younger patients with connective tissue diseases and vasculopathies. More commonly, it presents with subarachnoid hemorrhage, but it can present also with occlusion and strokes. So in this case, the artery is completely occluded. So the distal part of the artery is occluded, but this obviously is at a high risk of a rupture. So we sacrifice this artery by one or two coils over here, you can see, and there is the CT following. Obviously, this artery is going to be taken over by collaterals, but this territory was anyway closed because the artery is dissected over there. And this is a curative treatment, and we don't expect this to recur. This CT was done 1 year after the treatment. So dissecting aneurysms are responsible for almost half of all pediatric aneurysms, and they often are quite large. The common locations are in the supraclinoid ICA, but also in the M1 MCA, on the ACA as it turns around the forks, as well as the PCA in this location that I showed you. So they can often present with bleed because if you look at these 4 pictures over here, it depends on what happens to the blood flow. So if the adventitia leaks, then it's going to present with a subarachnoid hemorrhage. However, if it opens out into the intima, it then gives you the classical double barrel appearance of a dissection with true lumen and false lumen. If the false lumen starts clotting and the clot starts increasing in size, you can have a complete occlusion of the flow, and then these present with stroke. And then it can also clot off the perforating arteries and cause perforator ischemia. So these are sort of a very broad ways in which these dissections can present in children. Here is a 13-year-old boy who came earlier this year with a thunderclap headache. He had a background of type 1 diabetes. And the MCA, as it crosses a sphenoid wing, is also a common site for the artery to get dissected. So this was a presumed dissection of this artery. You can see a contained rupture and a pseudoaneurysmal dilatation of the MCA. But the MCA, you can see, continues distal to the artery. There is a reconstruction of the catheter angiogram. So the MCA artery comes in and then comes out, but there's this disconnected part which is dilated. And this is the part of the artery which is presumed to be dissected. So in this case, again, we take down this artery after checking, obviously, for collateralization of the distal MCA circulation. In this case, he passed it. So we are able to deconstruct this artery by packing the outflow, packing the aneurysm, as well as packing the inflow, and then bring back the normal anatomy with that distal territory being fed by ACA and PCA collaterals. As I said, these dissections can also present with a certain stroke. So if that lumen, instead of reopening, completely shuts down because of clot in the false lumen. So here, if you look at this dissection, exactly in the same location as the previous aneurysmal dilatation that I showed you. But in this case, the adventitia has not leaked out. If the adventitia leaks out, it forms a subarachnoid hemorrhage. But here you can almost see the second lumen where it has clotted off, and it closes the artery because of the acute clotting. It shuts down the artery, and these present as stroke. So this is exactly the same location. You can see the susceptibility in the clotted false lumen, and these can also present with strokes. In children, you can see these syndromic associations of aneurysms, and you can get these very dysplastic fusiform appearances in conditions like neurofibromatosis, progeria. But you can also get these focal saccular aneurysms in sickle cell disease, in different types of dwarfism like Seckel syndrome, and so on. Now, we published on our non-ruptured syndromic aneurysms a few years back, and most of the time we follow them, and unless they grow in size or they become symptomatic, we tend not to treat them, and they typically tend to do well. The exception to that, obviously, is some of these kind of conditions like mycotic aneurysms or iatrogenic aneurysms. So here's a carotid injury from an intraop. So there was a tumor which was being biopsied, and there was injury to the supraclinoid ICA. You can see here a superior hypophyseal location of this pseudoaneurysm pointing medially. Unfortunately, this girl failed balloon test occlusion. You can see there's also a lot of vasospasm at this time from the subarachnoid hemorrhage. But the easiest way to treat this is to sacrifice this artery. But unfortunately, the girl failed the balloon test occlusion. So we went ahead with reconstructing this artery with flow diverters. So you can see here the coil inside the aneurysm, as well as two pipeline flow diverters, and we are able to completely reconstruct this this circulation. So finally, I should say that all of these things that we do, obviously, it's teamwork between so many different services, whether it's surgery or our ICU colleagues or neurology and different services across the hospital. And this becomes crucial because a lot of these diseases that I have described to you are quite rare. They are not something that we see on a daily basis. So it becomes very important to have all our colleagues on the same team with us and have these discussions and have the best information we have available before we go into these kind of cases. And unfortunately, in the pediatric world, we don't see the typical cases. You don't always see a PCOM aneurysm like in an adult. You get these very weird cases, and so it becomes important to put your heads together and have these kind of multidisciplinary outcomes. And one of the things that we do is we form these institutional teams. So I'll give you one example of this. So we have this VAD stroke prevention group. So the ventricular assist devices which are put for children with cardiomyopathy. We form a group with the cardiologists, the cardiac surgeons, stroke, thrombosis, myself, and we in our institute there are about 5 to 10 children every year who get a ventricular assist device. So there's a unique stroke pathway just for these children, which is separate from our code stroke pathway in the children. And these children get a pre-surgical stroke risk assessment. Obviously, they have a device, so they cannot get an MRI. Stroke is a completely different, it's a separate discussion that we can have, but I just want to show you one case here. So this was a few months back, actually. This boy had a cardiomyopathy, a DCM, and he has this ventricular assist device, but he didn't wake up the next morning, and when he woke up, he was hemiplegic. The CT showed this infarct in the internal capsule and basal ganglia. Aspect score was 7, but we don't rely much on aspects because most of the time we do MRI, but you can see the complete cutoff of the right-sided MCA. By the time we did the angiogram, you can see the thrombosis has extended all the way down to the internal carotid artery. So even though this looks like a dissection, this is not. This is basically no flow going into the artery, so nothing is able to go integrate. So we then went ahead. You can see here a triaxial system with a Solumbra technique with the stent retriever and aspiration. And after, so there's the stent across injection. One pass later, there was still a little clot in the MCA, and then the second pass, we were able to take that out and achieve a full recanalization. There is his 24-hour CT. He shows no edema, and there's his old stroke, but no new stroke. And very fortunately for this boy, just about 2 or 3 weeks back, he got his transplant, and he has made a fabulous recovery. So these kind of outcomes you can really push with these collaborative methods that I discussed. But everything is not always perfect. We all have, if you do enough, you see complications as well. Things can go wrong. Here is a PL fistula, 4-month-old girl that we were treating with glue injection, and there was a massive arrest from this glue cast, which was closing the fistula, but suddenly everything got sucked into the venous side and then ended up in the pulmonary artery, and this child had a massive arrest on the table. Similarly, we have on the arterial side, here's a baby with a vein of Galen malformation when the catheter got stuck inside the glue cast and caused a rupture of one of the posterior choroidal arteries with a massive subarachnoid hemorrhage. Fortunately, this child survived, but the long-term development was obviously limited. You can see the MRI after 1 year showing this occipital infarct over here and volume loss on this side of the brain, and an incompletely treated malformation because the parents obviously at this point don't want any further treatment. Similarly, we see thromboembolic complications as well. This is an 18-month-old. So everything went well. I don't remember what we were treating exactly, but after the procedure finished, everything went well. We did the injection, and then we see this little clot in the MCA bifurcation, and then you can see the dominant MCA branch is slowly shutting down. So we then went ahead, did a thrombectomy, and we were able to completely revascularize this artery. But the child had some DWI hits as expected, but was asymptomatic. And this is now about maybe 3 years back, and the child is doing very well. So I think we have to keep in mind that we balance everything that we do, not just with our limitations, but also with the understanding of the disease. So I think I'll stop there. We looked at a spectrum of pediatric neurovascular diseases, and we touched on some of the more common ones, on the high flow aspects, and then how you actually make these decisions based on anatomy, but also on the pathophysiology of the disease. Some of the special considerations in the pediatric world and how we would approach them and modify techniques in order to get the best possible outcome. So thank you for having me, and it was really wonderful to be able to give you guys this lecture. I'm happy to take any questions now.
Does anyone have any question for Dr. Prakash? Congratulations, doctor. That's amazing, really amazing. I have just a curiosity. Have you used some type of the artificial intelligence to diagnose neurovascular disease in your hospital?
Artificial intelligence? No, not.
Oh.
There are some studies that are going on the diagnostic side, but those are more for white matter diseases, neuroinflammatory conditions. So far, I think the rarity of these conditions does not allow us to have the numbers to train an AI interface.
Okay, what about the stroke in adult patients?
Yes, so in adults, there are a lot of AI protocols which are being used for diagnosing, as well as for prognostication, for the penumbra identification and so on. But those are not standardized in pediatric practice, so we are not using those. And in fact, as you know, in the adult world, CT is used more for stroke, but our code stroke patients go straight to MRI. So we do MRI because we see so many mimics of stroke. So maybe 10% of pediatric strokes are actually large vessel occlusions. The others are mimics like moya or mitochondrial diseases and so on. So they go straight to MRI.
Okay, thank you so much.
I have a question.
Okay.
Can I make a question?
Sure.
Dr. Prakash, first of all, thank you. It was an amazing lecture. Very difficult cases. We know how challenging it is to treat these kids with vascular diseases, and your experience is impressive. Thank you for the lecture, first of all. And second, I'd like to ask you, it's been I have some difficulty in making this distinction in MR cases of AVMs. What are the criteria that you use to make the differentiation between PIO AVMs and proliferative angiopathy? So this is something that I have read the first paper by Professor REUNIÃO that described this entity of proliferative angiopathy, and I really have some issues in making this distinction, and I believe it's a kind of a spectrum, and sometimes things are kind of messed up. I'd like to hear from you. What's your opinion? What's your experience? What do you use and on a daily basis to make this differentiation. And thank you for the lecture once again.
Thank you. Thanks for that question too. So obviously we see the proliferative angiopathies. Some of them are very classical. They present with headache or seizures, and they have a diffuse nidus. They have ECA supply, and then it becomes a very and usually they don't present with hemorrhage. So we know that these are CPA. But sometimes we have a more classical presentation of a diffuse AVM, but over time it even grows more. So I do believe that there is a spectrum that we don't recognize. I even remember one case, a cerebellar AVM, which was completely treated, which we thought was an idle AVM. And then it came back and was gamma knife treated, and came back again. And after maybe 8 or 10 years, the whole cerebellum becomes proliferative angiopathy. And we could never predict that. If I go 10 years back and again I see, I would not predict that. So I think there is a substrate at the molecular level, which maybe it's VEGF based or not, we don't know, but which creates this growth in two different channels. But there is a spectrum in between, and in one end we have the definite CPA, one end we have a definite AVM, and there is a lot of overlap in the middle. So what we try to do is, if we are in that situation, we try to see where the risk is more. Is this more of a AVM hemorrhagic risk, and then we tend to treat it. Recently, I treated a girl with proliferative angiopathy, and she had severe headaches, and I very focally embolized some ECA feeders, but it did not give her any improvement. So I abandoned that pathway. Right now, we are actually doing a combined study with colleagues in Boston and London, and we are studying cerebral proliferative angiopathy. So we are putting together cases, and we are trying to, exactly what you said, to come up with a way to distinguish based on CT and MRI and catheter angiography and clinical features, how we can distinguish one from the other. But I agree, it is not something that is very well defined.
Thank you. Yeah, it's really challenging. Thank you.
Anyone else have any question? Dr. Pablo?
Thank you.
Can I make another question? This is the last one, Prakash. I promise you.
No problem, Dr. Leandro. Thank you, Dr. Prakash.
I'd like to hear from you about the cavernous sinus hemangioma, which is a kind of a distinct entity. Is it considered like a low flow vascular malformation? Am I correct? This is not a tumor. The cavernous sinus hemangioma, it's like a venous malformation. Am I right?
Correct. So I think in the rest of the body, they have shifted to using the term venous malformation.
Yeah, that's it.
But I think in the brain, we have still kept the old terminology. And in the spine also. But even I think the spinal hemangiomas that we see, the vertebral hemangiomas, they are slow flow venous malformations. And sometimes when you do the catheter angiography, you can see exactly the same puddling of the venous lakes. Yes, I agree.
Okay, thank you. Amazing lecture once again. Outstanding cases. Thank you.
Thank you so much.
Okay, congratulations again, doctor. Thank you so much. You are very clear in your lecture. Congratulations.
Thank you so much. Thanks for having me. It's really my pleasure to be able to discuss these things.
Okay.